that way. For those who are still at church and doing family activities, they won't miss out. All right, so last night we kind of finished up with the electrolytes. I believe the only thing we didn't cover, which was diabetes insipidus, so we're going to kind of start there. But before I do that, just kind of putting things into perspective just for fluid and electrolytes as a whole. Remember that your geriatric population is going to have a little bit more difficulty because of age-related changes. So what are some age-related changes that will cause really alterations in fluid and electrolytes as well as their acid-base balance? So give me a couple that you have learned about. Not feeling thirsty. Okay, so they'll have decreased renal function. Yep. What else? Besides decreased renal function. They could have an increase in BP. It kind of depends. But let's look at body systems. So we got the kidneys. What else? So the question for those that are just joining is, what are some age-related changes of the elderly that can impact their fluid and electrolytes? So we're just looking at organ systems. Okay, skin, their elasticity, cardiac, GI, lungs, perfect. So are those things we have decrease in renal function, so will we have a decrease as well in cardiac and decrease in lungs? In their functionality? Correct. So because of the decrease in cardiac, renal, and respiratory function and their reserves, there's alterations in their body fluids and muscle mass, and these things cause them to have an altered response or an abnormal response to fluid and electrolyte imbalances as well as acid-base disturbances. So we'll just start with the respiratory system. They have an impaired regulation with their they'll have an impaired regulation if they have like a trauma or any kind of major illness. Their kidneys, and that's like with anybody else, all your kidney function is going to decrease with age. They have muscle mass and daily, their daily exogenous creatinine, it's going to be lower. Therefore, they could have a high to normal or a minimally elevated serum level can actually be more substantial in an elderly person than if you had that in a younger person. So if my serum creatinine level went up a little bit, most physicians probably would not, put too much homage to it. If an elderly person's creatinine level goes up slightly, that is a significant finding because we already know they have impaired function. So this could indicate something a lot more serious. The creatinine indicates substantial reduction in the renal function, which we already know, and we know that they're already going to have renal impairment issues. Decreased concentration of the body fluid can alter the physiological responses, and that's because of the muscle masses decrease. Then we have elderly patients that take multiple medications. So they have, polypharmacy, which means many meds. And some of those can affect the cardiac function. Some of those can affect the renal function. So it just kind of depends on what they're taking, but ultimately increasing their imbalances to electrolytes. Anemia, they can, depending on their blood volume system. So that can happen as well. If you have an elderly person that has a fluid and electrolyte imbalance, how would they present compared to a young or middle-aged person that has a fluid and electrolyte imbalance? So this would be more, what's the common or the first sign that you may notice in an elderly person? They're going to have a change in LOC, correct, Jacina? Correct, Terrace. So they'll have more delirium. For your person that has your younger person, then their first sign of fluid volume deficit is going to be increased thirst. So we have this, you could have the same electrolyte imbalances, but they'll present completely differently. What is the concern if you were to replace IV fluids for an elderly person compared to that of a young or middle-aged person? Are there any types of cautions related to that? Or should we be concerned one way or the other? Fluid volume overload. Thanks, Christy. So in elderly, we're always worried about FVE, so fluid volume excess. The other thing we're worried about is their cardiac function. Remember, they have a decreased cardiac function. So if we give them too much fluid, even if it's, and we're going to talk about what too much fluids is, would be in just a second. So if we give them too much, then we can actually put them in heart failure. So that's the reason why we don't want to just, give them all kinds of liters of fluid. So if you're concerned about an elderly person, dehydration, and you want to give them a fluid challenge, what type of fluid challenge would you think would be acceptable to give that elderly individual? So this would be like an IV fluid bolus. What would be an acceptable amount of fluid and we're just talking about total volume, to administer to an elderly person to get their volume status up? 500 in a 24-hour period, okay. But if we got to give a bolus, then what would that equate to? Because if I divide 24 into 500, then that's going to be a small amount of fluid. Not sure. Okay, I can accept that. So in practice, if you have someone that's dehydrated and you need to give them a bolus of fluid, how much can an elderly person handle based off of their age-related changes for a fluid bolus? So sometimes a fluid bolus is a half a liter. Sometimes a fluid bolus is a complete liter. Sometimes a fluid bolus is a quarter of a liter or 250 mLs. So my question is, of those three, which would be appropriate to give to your elderly patient without causing further cardiac demise or causing fluid volume excess? That was basically the question. So 250 would be an appropriate amount. And that may be too much, but you'll start there to see, and you'll still monitor. You just don't hang it up and then walk out the room and don't pay attention. Then you come back and your patient's short of breath and, rails and all of that. So you just want to make sure that you start at the lower end. You just don't give them a liter of fluid and then, oh my God, I didn't realize that was going to be too much. So you have to understand with those age-related changes, even a small volume like 250 mils may be too much depending on the individual. The same thing would be applicable to a kiddo. So you wouldn't hang up a liter of fluid on a kiddo and walk away. That's the reason why some facilities still use those Buretrol sets, because you only can put in X amount and that's all that's going to go in. So just kind of thinking about those particular things. When you're looking at dehydration, this is when they have a rapid loss of body weight greater than or equal to 3%. So they're either losing water or they're losing sodium. So when they have that loss, that's when the body now is dehydrated. Patients may have dry mucous membranes. They could have poor skin turgor. Elderly people can have delirium. So those are all different things that can happen. So we've associated an alteration in mental status to UTIs, right? Urosepsis. We've also associated it to pneumonia. And now we can add on fluid and electrolyte imbalances, but more specific, we can add that piece in that we have to look at those particular changes. So elderly folks, if they become dehydrated, it's probably because they have a decreased kidney mass, their glomerular filtration rates decreased, their blood flow to the kidneys decreased, their ability to concentrate urine has decreased, their inability to conserve sodium is a problem. They have a decreased ability to excrete the potassium, which is K, and they have a decrease in total body of water. So all of those things will contribute to fluid and electrolyte imbalances. So any questions just about the age-related changes of the elderly folks? Because I didn't want to take that out the game. All right, so we talked about syndrome of inappropriate antidiuretic hormone. So let's talk about diabetes insipidus. So does this have to do with blood sugar? No, Christy already knew what I was going to ask. Okay, so why do we have, or why would a person develop diabetes insipidus? And Amy Lee, correct, they have an underproduction of antidiuretic hormone. What organ is responsible for ADH? It's the pituitary, but it's actually the posterior pituitary. Okay, so there's some dysfunction in the posterior pituitary lobe. And what's the end result when we have an underproduction or somehow maybe a misutilization of antidiuretic hormone? They do become dehydrated, but why? What's happening? Because they have, is it just a little bit of urinary output, or is it like excessive large amounts? Correct, it's major, it's massive. You know, your book may refer to it as, you know, large volumes or excessively large volumes. They do urinate out all their fluid, but here's something to keep in mind. What happens if you withhold IV fluid? If you withhold, you know, PO fluids, do they continue to urinate out? Yes, they do. So even if you say, okay, this person's thirsty, but we're going to hold the fluids, the body is going to continue to urinate out. So that's when they become extremely dehydrated. So it's a water balance regulation disorder that's kind of related to a decreased secretion of antidiuretic hormone. But which antidiuretic hormone are we speaking more specifically of? What's the name of that antidiuretic hormone? Anybody? Somebody has to know what that antidiuretic hormone is. It starts with a V. I'll give you that, and ends with an N, like in Nancy. Vasopressin. All right. So remember, just don't know you got to, you know, can't stop short. Because it may not come up as antidiuretic hormone. It may say vasopressin production deficit. And then you're like, what's that? So know the whole piece to it. So because of it, they end up with, they call hypotonic polyuria. And they also have excessive thirst, which is polydipsia. But we've seen those conditions before in what? Polydipsia and polyuria. Where did we see those before? In diabetes, but in metabolic diabetes, okay? So it's in both diabetes, 1 and 2. So this is why you have to understand that diabetes insipidus is not true diabetes, but because it has similar signs and symptoms of diabetes, you know, this is why people confuse them. So insipidus is pituitary, diabetes mellitus is pancreatic related or pancreatic driven or metabolically driven. So that's how you compare and contrast. So don't confuse them with the other diabetes, but they do share that polydipsia and that polyuria. Okay, so there's 2 types. There's your PowerPoints, I believe, identified 4 different types. And you're probably saying, do I need to know all these types? But I think if you put all those pieces together, we're not going to label it out as primary, secondary, etc. But they're all causes that or things that can lead a person to develop diabetes insipidus. Does that make sense? Okay. So you have the central, which is basically, you know, the pituitary, the neural hypophyseal or neurogenic. And that's because there's a lack of secretion of vasopressin due to destruction of the posterior pituitary, whether totally or in part. So where the vasopressin is being stored, that area has suffered some damage some way, somehow. The other forms could be caused by improper development of the pituitary gland or over rapid destruction of the vasopressin by the placenta, which is a gestational. We also have from trauma, from head trauma, from tumors. Then person may have an adenoma, so they may have a pituitary tumor, which they call an adenoma. And an adenoma is basically a glandular tumor, so it could be any gland in the body that has a tumor, okay? There's also drug-induced diabetes insipidus, like lithium or declamycin. They're usually drugs that may cause a person to develop DI. You can have the kidney tubules that don't respond to the actions of antidiuretic hormone is the reason why the person develops ADI or ADH or DI. You could have traumatic brain injury. You can have neurologic infections like meningitis, encephalitis, or tuberculosis. Yes, Christy, declamycin is used for SIADH, and it can cause DI. So remember, and why is that possible? Remember, the goal of declamycin is to help increase the sodium, because in SIADH, they have hyponatremia, correct? Would that be a correct statement? Okay, so if you give a person a medicine that's designed to elevate a particular electrolyte or change a particular function, then it can actually take them all the way over to the other side. So this is why we have to continue to monitor serum levels of sodium to make sure we're not causing them to have hypernatremia and potentially putting them in diabetes insipidus. Does that make sense? Okay. All right, so I think we kind of covered some of the main causes. There's others like, you know, congenital malformation that can happen. It could be familial, it could be idiopathic, so, or insidious. It just depends on the situation. What about the one thing I didn't mention is if a person has a hypophysectomy. What is a hypophysectomy? Yes, it is. It's pituitary surgery. So if they have removal of the pituitary gland, then this can also predispose them to diabetes insipidus. So there's a lot of different issues. Kidney disease, chronic hypercalcemia, or chronic hypokalemia can lead to what they call the neurogenic DI. So that's basically related to the kidneys. Not neurogenic, nephrogenic. So if you have too much calcium or too little potassium, that can actually put a person into nephrogenic DI. Let's spell that out. Hold on. I'm typing. All right. Makes sense? Okay. The only other thing that I can think of as another cause would be starvation or anorexia. But DI is it's not like a common condition. And a lot of times people may not catch it because it does only happen in about 3 in every 100,000 people. So it's not like it happens on a consistent basis. But if it's not treated, then the person can end up with hypovolemia or hypovolemic shock, right? From all that excess fluid volume loss. Circulatory collapse, that would be a huge issue related to the, or two big complications that I would be concerned with. When you're looking at DI, I've already said it could happen insidiously or abruptly. So what does insidious mean? Not the movie. That they're asymptomatic, it does happen silently. So basically, by the time signs and or symptoms are identified, permanent damage has already occurred. That's what insidious means. It's hidden, but it doesn't mean that it hasn't been there. It's been there pretty much, you know, on the DL, on the down low. By the time the person catches it, or the physician, that condition is well advanced and permanent damage has already been going on to target organs or to end organs. So it's kind of like hypertension. When we talked about that, the hypertension is kind of insidious, especially for women. By the time most of them realize they have it, permanent damage has already happened. So things your patient might report is that, I've, been peeing quite a bit, and you're asking, well, how much are you peeing? And they're like, I'm just peeing a lot. And you're like, well, what does it look like? And it's like, it's really clear. Sometimes it looks like water. So, they may have peed out between 2 to 20 liters in a day. That's a lot of urine, especially when you know that your body has only about 5 to 6 liters of circulatory volume, correct? So they may also report weight loss. They may also report that, I'm super thirsty. I'm drinking a bunch of liquids. I'm weak, I'm dizzy, I'm constipated. I have a headache. All of those are things that may be reported, but their urinary output is about 250 per hour. So correction on the 2 to 20. The 2 to 20 is how much they're taking in. They're peeing out about 3 liters in a 24-hour period. So they crave a lot of cold water. They drink a lot of water. So they're drinking as much as they're drinking more than what they're putting out, but they're still putting out a lot. I'm typing just for clarity. All right, so they drink 2 to 20 liters per day, but pee greater than 3 liters per day. All right, so what would the specific gravity, what would you expect their specific gravity to be? And although I haven't talked about osmolarity and osmolality, serum and urine, you need to know that. So I don't want that to go unaddressed. So what would you expect their specific gravity to be? Decrease, like how decrease? How low? Give me a number. How would you reckon if I said, blah, blah, blah had specific gravity of a number? How would you know what that really meant? What number would you be looking for? Okay, so isn't specific gravity like 3 decimal places out? So wouldn't it be like 1 point, something like that? I didn't finish my statement, but that was my first statement. But now for specific gravity. So when you're saying that it's going to be low, would that be low? Yes or no? Would that be low for specific gravity, or would that be normal? Which one? Is that a high number or a low number? Let's look at this part. Maybe this, what is normal specific gravity? I think that will help clear up if this is a high or low number. Okay. All right. So you're about in the range. So like 1.001 to 1.030. So if we are looking at diabetes insipidus and it's more dilute, based on this normal range, where would DI fall? Okay. So why on the upper end? What does the upper end represent? I think that's the question. What does the upper end represent? So the upper end would represent dehydration. Okay, so I don't disagree with that. So specific gravity kind of measures the ability to excrete or to conserve water. When compared to water, your specific gravity would be 1.000. Normal is 1.010 to 1.025. So it varies inversely with urine volume. Increased urine volume equals decreased specific gravity. So the more you pee out, the lower the number will be. Okay? So we have someone that's in DI. So if they're peeing out a lot, then they can't be at the upper end. Does that make sense? So you have to go back and look at what osmolarity, which basically describes the concentration of the solutions. You have to go back and look at factors that affect osmolality. So if your osmolality is up, then your specific gravity would be down, and vice versa. So it wouldn't be less than 1.001, but normal specific gravity for DI is that number. So it would be between 1.001 and 1.005. Let me clean that up. So this is why it's important. You probably saw osmolality and osmolarity and you're like, whoop, over my head, and you just let it be. But you needed that piece to help understand some of these other conditions, okay? And then you have urine, and then you have serum. So there's, you have two different factors that play a role. So you have to understand, how each of those work. All right, so we've already talked about urinary output that's greater than 250 per hour. It's going to be very dilute, so it's going to be on the lower end of the specific gravity, so 1.001 to 1.005. There's no abnormal substances in the urine, so you won't have any glucose, you won't have any albumin in there. And the patient will probably say, I drink all the time. I'm drinking liters per day, so that could be between 2 and 20 liters. But they're putting out 3, 4, 5, 6 liters of urine in a 24-hour period. That would not be uncommon. So your signs and symptoms that you would see on your patient. They would have signs of dehydration. They would have the dry mucous membranes. They would have poor skin turgor. They would have pale, voluminous urine, so large volumes. They may have decreased muscle strength, hypotension because of the low volume. Why would they have flank pain tenderness or flank pain or flank tenderness? What would be the significance there? Think about what's happening to the kidneys. So wouldn't the kidneys be kind of stressed? Putting out all that urine, not being able to get the right filtration, that's all low. Okay. Other thing would be dry skin. So we've already talked about that as well. What about our labs? What will we expect for our labs? So we've already covered the specific gravity, that's going to be low. The urine osmolality is going to be less than 200. What's normal for urine osmo? So what's normal for urine osmo? Did anybody even look at that? We're talking about the urine part. So we're talking about urine osmolality. .500's a little high, but the 800's correct. So normal is going to be 200 to 800. That's for urine. And then we have serum. And serum osmolality, the number is completely different. The window is not as large. Okay. So there is a table in your book, in Brunner, that kind of covers the whole serum and urine osmolality. I highly suggest you guys go back and look at that and just understand, because understand it just to, I would look at it based on conditions. So if you go there, you'll see that serum osmo for DI would be increased. So it kind of helps put those things into perspective. I don't think you'll have to go in and like really slay a whole lot of time into it. I think if I were you guys, what I would do is, okay, which things would I expect to have serum osmolality? And so as you've already made your little note cards about hypernatremia, DI, those things that we're talking about, then I would slide in serum osmo would be elevated, urine osmo would be decreased. So although the serum osmolality in DI would be elevated, the urine osmolality in SIADH would be elevated. Does that make sense? So you would almost have opposite. So if I'm dealing only with DI and I'm looking at my serum and my serum would be up, but my urine for DI would be down. And then if I'm looking at SIADH, then my serum for SIADH would be elevated, but my urine for SIADH would be down. Does that make sense? Anybody? Need a break? Christy says yes. Okay, so which part you want me to kind of take a step back and regroup on? Which part? No, no one has a question? Okay, so what I did, and I don't even know if I can share this because I actually wrote it down, but what I did is I kind of took the chart that was already in the book. I don't know, can you guys see that? So I just basically did a chart similar to that. And so that was my factors to increase osmolarity. And then those were all of those. And then at the bottom, I looked at the urine ones and then I made it a different color. So that way I knew what I was making a different color of. So then I went on the other side. I'm trying to see if I can. This was factors to decrease osmolarity, but it's still the serum component. And so when I did this piece, then I basically went through and wrote things that's going to decrease my osmolarity. And then when I looked at the urine piece, those were the things for the urine. Does that make sense? So this is what I'm going to say. Don't push a panic button because, I mean, literally, even though you all are muted, you're probably like, oh my God. So don't push a panic button. Why? Because all you have to do with what you've already done, someone says she knows. Yes, it was eerily silent when I said that. When you go back and you look at the chart, all you're really doing is adding it into exemplars that we're studying now. Does that make sense? So don't try to go and put in the whole shebang-a-lang. Don't do that. So I would do the severe dehydration. I would do DI. I would do hypernatremia because those are the things that we're talking about, right? Okay. Then I would look at fluid volume excess, SIADH, hyponatremia. Am I overhydration? Those would be the ones that I would stick to, would be the things that we're studying currently as far as the exemplars. That should really simplify that list because that makes, even though I have a long list here, or although there's a long list in your book, you, for this point in time in the game, would just look at those things that's related to the exemplars that you're currently studying. Does that make sense? There's no magnesiums, there's no calciums or anything like that. So it's fairly simple. I can't remember the page in your book. Let's see if I can. Trying to remember if I wrote it down somewhere. Let's see. I'm trying to see where does it start. I'm looking real quickly. Someone asked about IV fluids yesterday. You know, that's in your book on page 248. Which IV fluids do you use for what? I think that was Sydney. All right, give me about 2 more seconds. Okay, I found it. So I'm going to share my screen. So that way you guys can see what I'm talking about. All right, so everybody has this already. You should have your ebook online. Okay, so if you scroll down, it's when it starts talking about all the fluid and electrolytes, that's probably the part that you all did the eye roll and said too much information. So it gets to this section right here where it talks about osmosis and osmolality, right? So that's page 239. So when it goes into how the electrolytes work, the roles of the kidneys, you know, gives you little pictures and the diagrams about the difference between osmosis and diffusion. So it covers all of that, goes through the body systems, and this is the chart 13-3 that this information came from. So I would be looking at severe dehydration, you know, diabetes insipidus and hypernatremia, because that's what we're talking about now. Fluid volume deficit and SIADH, because that's what we're talking about now. Fluid volume excess and syndrome of inappropriate antidiuretic hormone and acute renal failure. So that would fall in, as well as these two right here, hyponatremia and hydration. So all the others I would take out. Does that make sense? And so here's serum, and then here's urine. So fluid volume excess, diabetes, I would.
You want something?
I want to go to the restroom. I don't want to go in there.
Uh-oh, I gotta go to the restroom. So that's how I would look at that chart. So all of this other stuff with the mannitol, et cetera, I would take that out the game for now, because I think you'll have still a clear understanding of your osmolality, serum, and urine just based on that. So it would just be one of those signs and symptoms or diagnostic tools that would further support whether they have DI or further support whether they have severe dehydration. Does that make sense? That's page 240, Amy Lee. So when you go to your textbook, it should be page 240. It has its table. Let me make sure I say it right. Table 13.3. Okay. So don't try to swallow this whole alligator at one time. Keep it simple. So if you did last night what I suggested about your silos, you're just adding in these pieces related to your exemplars. All right. Does that make sense? Okay, I think we can get away from the people peeing. Okay. All right, so just kind of, you know, I know it's tomorrow, etc. And if you had done your readings, hopefully you have done that. Then me mentioning about the serum and the urine osmolality shouldn't be an issue. Okay. All right. Now I'm going to get back to DI and back to the laboratory results. So we already kind of discovered based on the chart that our serum levels of sodium is going to be elevated. So we're going to have hypernatremia, right? But our serum osmolality will be up or down based on that chart. It's going to be up. And then that means if our serum is up, then what's going to happen to our urine? Would that be up or down? The urine osmolality, it's going to be down. Okay. So, and when we're saying serum osmolality is going to be elevated, it's going to be greater than 287. So remember, it's going to go past that 300 mark. The thing we have to look at is a 24-hour urine test. How do we collect that? What are our nursing priorities related to a 24-hour urine analysis? So that means you're going to have to be collecting that thing over 24 hours. Okay, so the first time the patient pees, we're going to chuck that urine. Then we're going to start collecting it after the subsequent voids after that, and we're going to put it, what color is that container, if anyone's ever seen it? Has anyone ever seen that container before? It's definitely a jug. It's like an orangish brown container, correct. So now you start pouring urine in there over a 24-hour period. Now, what are the must-haves to that container? It must be placed on what? It must be placed on ice. We have to keep that urine kind of cool. So at some point in time, if you remember, most people or most facilities will use that pink pail. You know, that pink pail doesn't go up, it actually goes out. So the pink pail is going to, that's going to be a little bit of a deficit when you get to, you know, how you going to keep all that cold. So they may have to resort to other measures, but it has to be cool. And its job, they're going to look at specific gravity. They're going to look at BUN, creatinine, and other things that may be, you know, in that urine, okay? We would expect their blood, BUN, and creatinine to be elevated. They could do the antidiuretic hormone, you know, serum test. They could actually send that off for lab. For as far as diagnostic imaging, they may do an MRI of the brain if they're trying to rule out that the patient may have a tumor. Other diagnostic studies, they'll probably be on water restriction to do a water restriction or dehydration test. Overall, we're going to treat the underlying cause. We're going to control fluid balance for diet-wise. We're going to prevent dehydration. So if they have, you know, nephrogenic, so that's kidney-related, diabetes insipidus, what would you expect our diet to be if they have nephrogenic? So when you say renal diet, what do you mean? Low sodium and low what else? Protein. So they're going to require a low sodium and a low protein diet. That's with nephrogenic DI. So let's talk about meds. What medications would we give for DI? And what's the route? Okay, so we're going to give vasopressin. Is it vasopressin or is it desmopressin? Correct. It's going to be desmopressin acetate or DDAVP. Okay. So that's, or you could give, and that's it. How is that given? Orally? How is DDAVP given? Sub-Q? How are we going to give that DDABP? We're going to give that intranasally, okay? You can give it orally, but overall, it depends on the patient. They will more than likely get it intranasally. So if they're going to give ADH or just vasopressin, then we could give that subcutaneously, okay? Other meds, can we use diabinese? Which is chlorpropamide. So it's diabinese. Oops, I almost spelled that wrong. That one. So that's the diabinese and chlorpropamide are the same. Secondary wise, in mild forms, we could give the diabinese or the chlorpropamide, or we can also give thiazide diuretics to help treat DI. If they have nephrogenic, then they're going to give them like a mild salt depletion or give them NSAIDs like ibuprofen or indomethacin, so they can also give that medicine to enhance urinary concentration ability. So there's several different treatments that can be used to manage DI. So what is DDABP, and does it affect your natural ADH? Does it affect your natural ADH? Anybody? Have you even looked at this medicine? So it's a synthetic vasopressin, and no, it does not affect your natural ADH. But we use it because it has a longer duration of action with fewer adverse side effects. So if we're giving it intranasally, we're going to give it 1 to 2 times a day over a 12 to 24 hour period at either Q12 or Q24. So if we're giving it twice a day, then we're going to give Q12. If we're giving it once a day, then that would be Q24. But remember, since it's vasopressin, it's going to cause vasoconstriction. So which patient population do we need to monitor very closely if we're going to give vasopressin? Older people, but why older people? What condition could the older people have that could be a complication here? Okay, coronary artery disease. So things like for the hypertension, etc. So good. All right, you guys are still alive. Yay. All right, so what are things we're going to talk to them about? You know, we're going to give them the intranasal desmopressin. If we give them IV fluids, then we need to make sure we get IV access, give IV fluid replacement. You know, usually no more than 500 to 700 mils per hour to prevent fluid overload. Monitor their hemodynamic status, so lungs and heart, so you have cardiac issues. Encourage them to take adequate PO fluids, ensure that the patient has free access to water, daily weights, check skin turgor, anti-embolic socks or sequential hoses, so they may have TED hoses on, or they may do the SCDs, which is the sequential compression devices. We're going to do daily labs. We're going to prepare the person if they have to go to surgery. We're going to educate them on the importance of follow-up care and making sure they have their medications available with them and that they have a medical alert bracelet and prevent complications. And if they have nephrogenic, then they need to do low protein, low sodium diet, right? Can can the diabinase, can that cause an individual with DI to end up with hyperglycemia? So if they get the diabinase or the thiazide diuretics, do we need to monitor them for hyperglycemia? That's the question. Yes or no? And I don't care if you're wrong. I'd rather you be wrong here than any place else. Correct. Yes. So you have to monitor if those mild forms of DI, if we're given the diabinase or if we're giving them thiazide diuretics, then we're going to have to monitor them for hyperglycemia. Okay. In your book, I want you to do the ebook. I think it's 285. Let me see. Let's make sure. Wrote myself a little note this morning of something that I wanted you guys to do. There is a case study. There is a case study of all of the, that kind of covers all of the electrolytes. And I want to make sure I get the right page. So at the end of chapter 14, I believe this is, let me make sure. No, at the end of chapter 13. So chapter 13 has all of the fluid and electrolyte imbalances. So after chloremia, they cover all the chloride abnormalities. There's a little case study at the end that actually will kind of solidify everything of what we've talked about. And this will be, it's like 18 slides, but it's Mr. George Smith, that's an 82-year-old man. So it'll be case study part 1. Do you guys see that? It'll be on page 267 is where it should come right along in there. And it'll be electronically though. Or I'm not sure if it's in the book. I'd have to go pull my book out again. But right around 267, they'll if you're using your ebook from Lippincott, then it'll say, click on it for further whatever. And as you go through, read the scenario, then you'll have to provide answers to, the vignette that they've provided about the electrolyte imbalances, his medications, renal failure, etc. And then it starts to ask you to differentiate between fluid volume excess and fluid volume deficit. Then it asks you to list the signs and symptoms of the different electrolyte imbalances. So this would be a good way to kind of solidify your knowledge base. And then it gives you a part 2, kind of like we do with when I have the Prusser and Willingham's case study. So I actually went through this case study and I actually like it. And you get to have real-time answers related to it. So if you're online, then click on go to your ebook, and it's going to be chapter 13, but it's going to be right at the end of chapter 13. And so you get little assessment follow-ups. You get to see your answers right away and rationales as to why, the direction you need to go. Make sense? Are you guys looking for it? And all of the meds that we've talked about, the Kxalate, the calcium gluconate, all of those are in there. And then it gives you kind of a recap at the end. So, oh, someone says looking. Okay. So yes, it's going to be right after, you can go to your, mine's is listed in page. That's not my call, Jacinia. That was Miss Johns's call. Someone said it's due the 2nd, which would be tomorrow. Today's the 1st. Maybe she gave you a break because today was Easter. So I don't know. So go on Lippincott and check to see when it's actually due. So that way you're not late with it. Okay, guys. So have you all found the case study or at the end of chapter 13 in your ebook? So it's on Lippincott. And you don't have to do it now, but that'll be something to kind of test your knowledge base, to see where you are. All right, so I think the last thing would be the chronic renal failure. So with chronic renal failure, how quickly is that discovered? Is that discovered like immediately? Wrong button. It's discovered late. So when it's discovered, then although there's been gradual loss of the entire nephron unit, by the time they discover it, then they've lost 70% of their functioning nephrons, which means it doesn't matter at this point. They're going to end up either needing dialysis or kidney transplant. Now, sometimes over time, a physician, if they're tightly managing your labs and looking at your electrolytes, specifically your BUN and creatinine, then they'll discover it a lot sooner than later. But, they're trying to figure out how do we, stop this process. So usually someone with high blood pressure, diabetes, these would be individuals that are more prone to developing chronic renal failure. Now, you can have acute kidney injury. That can happen. That can happen with a trauma. It can happen with dehydration. That is possible. However, when you have something that's chronic, that means that it's been happening for a long time, and somehow that was not recognized, not addressed. And maybe the person didn't seek help. So that's, we have other issues that we'd have to, consider at this point. It doesn't mean that, they just ignored it. Maybe they didn't have the access. Maybe, they didn't have insurance. So there's a variety of reasons why that could potentially happen. Either way, it doesn't matter. I mean, once you get it, it's here. You have to now try to address it and move on from that particular component. So we can't stay stuck in that one section as to, why didn't you do this? Why didn't you do that? It doesn't matter. At the end of the day, we have to now figure out what we're going to do to help the individual out. So towards the end of the session yesterday, we talked about some things related to, assessments and things that we need to do. We understand or should understand that their glomerular filtration rate has been, affected. They may have more solute particles that are filtered to compensate for the loss of the renal mass. They may have an increased demand predisposed, the remaining that's going to predispose the remaining nephrons to glomerular sclerosis, and so eventually ending up in destruction. So the key here is that overall they're going to have a continued loss of urinary function, the glomerular filtration rate, the nephrons will continue to be attacked, for a lack of a better word. Okay. So other things will be diabetic nephropathy. So that's obviously from diabetes, hypertensive nephrosclerosis. And what does sclerosis mean? Um, I don't know exactly what's on that. I don't know how to answer that, Yesenia, because I haven't seen it. So it's up to Miss Johns at the end of the day. I'm just going to cover it, and then that way, if it is a question, then you won't be like, well, she said it wasn't going to be on there, so I'm just going to cover it anyway. So sclerosis means hardening. So that means that now the vessels and the kidneys are hardened due to hypertension. So we have that going on. We can have chronic glomerular nephritis. So that's an inflammation of the glomerular. We can have chronic pyelonephritis. So that's basically another kidney disease, or it's a kidney infection that's gotten all the way up into the calyces and where the medulla and the cortex is. They could have polycystic kidney disease. So, they're, making cysts on the kidneys or cysts in the kidneys. And then a person with lupus, they can also predispose them to chronic renal failure. So that's where the membrane's damaged by the circulating hormone, the circulating immune complexes, and it can, lead to having a diffuse glomerular nephritis. With the multiple bilateral cysts, it gradually destroys the normal renal tissue and by compression. So all of those are issues that can absolutely lead to chronic renal failure. So there's some structural and functional abnormalities related to that. As the function declines, then protein metabolism accumulates in the blood. Is that normal to have that happen? Okay, so that's not normal. And then they end up with uremia. What is uremia? It's basically those protein metabolism end products. So as it continues to decline, then we start having more issues that develops, and that continues to slow down their function. So Yesenia had a question about the 5 stages. I mean, this is how I would remember those 5 stages. The worst stage obviously is 5. They're putting out less than 15 milliliters per minute of urine, right? So that, or for the glomerular, it's not functioning as well. And I would just find a number. So like, less than 15, stage 5. Less than, from 15 to, pretty much like they have it here. It's kind of an easy read, or it's an easier read of what you had book and on your notes. So I would just understand where the person is. I don't know what Hessie's going to ask you. Yeah, stage 4 is 15 to 29. Stage 3 is 30 to 59. Stage 2 is 60 to 89. And anything greater than or equal to 90 is stage 1. So kidney damage, but they have normal or an increased GFR. So that's kind of, how I would look at that. Is kidney failure cheap? Does it cost, just a little bit of money to manage someone who has renal failure? No, it's highly expensive, and it's increasing. What population's more affected? Older, okay. Not all older, because you have some younger population folks that have end-stage renal disease. I've met some 20 and 30-year-olds. Someone said my sister, she's 28. Yes, it's not just older. More Native Americans, Asians, European Americans, African Americans, they tend to have those types of issues. So we should already know what from A and P, how our kidneys work and what they're designed to do, right? Okay. We talked about risk factors: diabetes, high blood pressure, polycystic kidney disease, infections like, pyelonephritis, certain medications, toxic agents like snake venom. That would be common, like here in Texas. Um, Recreational drugs, so cocaine, methamphetamines. For those folks who like to drink antifreeze, I don't see any real love for wanting to drink antifreeze, but some people feel it's the way to go. Environmental issues, lead, mercury, chromium. People drink antifreeze, yes, when they're trying to kill themselves. Yes, they do. Some people just drink it regularly and then take too much of it and realize, oh, okay, this might have been too much antifreeze. I personally have not tried to drink antifreeze, but some folks that have actually tried it said it tastes good. I wouldn't recommend doing it though. With yes, the car antifreeze, Yesenia. Yes, it's that one. I think it's disgusting, but it doesn't matter. Doesn't matter what I think. Looking at the clinical manifestations, every body system is affected. Cardiovascular wise, respiratory wise, all of those are going to be or have cause for concern. So at the end, the thing that usually takes them out is going to be cardiovascular disease. Okay, but they do have an accumulation of uremic waste products, which is a probable cause of most of the deficits that they do have. So your book kind of gives you a lot of information related to, how do you treat it. But remember, if their kidneys aren't working, they're not going to be able to empty out urine really well. Some of them have they go from being oliguric to anuric. There are some folks on that have chronic renal failure or that may have end-stage renal disease that actually do produce urine. It's not on a regular or consistent basis. It just happens. But when they hit that 5th stage, then pretty much their urinary output is non-existent. So they are usually fatigued. They're usually pale, confused. So they try to help them out with things like iron supplements, give them erythropoietin, blood transfusions. So these are all things that they give them to help improve their cardiovascular status, make sure they monitor their dietary process. They also look at if they're anemic, do they have hyperkalemia, because they're not going to be able to clear that. So we have to start doing other things. We do restrict the fluids because since they can't pee, that fluid is just staying in the body. So now they're having dependent edema. They're ending up with crackles or rales. They're short of breath. They can end up with pulmonary edema. So all of those things are not going to be good for them. Jugular venous distension. So their end goal at that point is to be dialyzed. So, restricting the fluids, it's kind of hard to do in Texas when in the summertime from, late spring to late fall, temperatures can be in excess of 100+ degrees. So, that fluid restriction is very difficult to stick to, even if they are going to dialysis every 2 days or every other day. So if you're thirsty, you're thirsty. The sodium restriction, that definitely helps. It helps to minimize the thirst. Even if you gave them diuretics, some people don't pee, so giving them diuretics is a waste of time. So it's a disease you definitely don't want on any level, because it's very frustrating, and that's the reason why a lot of those folks end up, becoming depressed. I don't know anybody who loves being on dialysis. I'm just going to be honest. It's really a very awful process. Other things we want to look for is if we do have hyperkalemia, then we're going to be looking at abnormalities in heart rhythms. So how do you know if they have hyperkalemia? Well, they'll have those tall peak T waves that we talked about earlier. They can also go into cardiac arrest. They do suffer from a lot of nausea, vomiting, and belly cramps. And I talked about that last night, especially after dialysis from all the fluid shifts. Muscle weakness. Some that could be as far as so severe that they can't really move it. So if we do have someone that has hyperkalemia, then we're going to try and go with the K-exolate so they can poop it out. But that don't be discouraged or shocked, or it's not really discouraged, it's more shocked if the physician orders dextrose 50% and to help and give them insulin. And if you give them dextrose 50% and regular insulin, what it's going to do is drive the potassium into the cell and get it out of the blood. Does that make sense? So you may see that trio form used where they're giving them fluids, but they're also giving them D50, and they're giving them insulin and K-exolate to help them poop it out and get the potassium levels lower. Okay. So if we give that K-exolate, remember we're going to check bowel sounds too. All right. So common electrolyte abnormalities that you will see with, you can call it CKD for chronic kidney disease or chronic renal failure. I think the new nomenclature is now CKD, would be sodium and water retention. So they're going to have edema, hyperkalemia, so increased potassium, hyperphosphatemia, so increased phosphorus, low calcium, because remember, if our phosphorus up, then our calcium is going to be down, hypermagnesemia, and metabolic acidosis. So, they get the hyperkalemia develops as the renal failure progresses. So that's why they have the muscle weakness and the paresthesias. The hyperphosphatemia, we have phosphate excretion impairment. So that's why we have that phosphorus hanging on, which means our calcium is going to be low. So how can we get rid of that extra phos? What can we give them? What medicine? Do you remember? Because someone brought it up last night. So what medicine can we give them besides the K, besides the binders? So it's an IV med. So if our calcium gluconate, thanks, Yodit. If they have impaired vitamin D activation, this will also contribute to the hypokalemia, or calcemia, not kalemia, calcemia. For the mag, the kidneys can't filter out the magnesium, so that gets stuck on there. So then we could use things, we're going to avoid magnesium containing antacids, so we may, for that individual. So we've kind of covered most of that. Our diagnostics, urine and a urine culture if they make it, but they're going to do a lot of blood work. So they're going to look at their glomerular filtration, their creatinine clearance, their BUN, creatinine, their electrolytes, and their CBC. So if they have an elevation in both BUN and creatinine, what is that condition called? Now, end-stage renal. So if you have both elevation in BUN and creatinine, it's called azotemia, is what it's called. All right. So no problem. We could also do a renal biopsy. They can also do a renal ultrasound. So there's a couple of things that can be done. to also further support. In your non-renal hyperkalemia, you could give diuretics. We could give calcium and phosphorus binders to help decrease your phosphorus levels, as well as the calcium glutamate. Hypertensive and cardiovascular agents, anti-seizure agents, erythropoietin to help increase the red blood cells and decrease the anemia. Folic acid and iron support, or iron supplements, and then a multivite. So if any of you have taken care of a patient that has had renal deficiency or chronic renal disease, and I know there were some of my students who did that at Kindred, then they were giving a diabetic multivitamin, and they were giving Procrit or Epigen or erythropoietin. Those patients were receiving those medicines. So that way, they can help improve their electrolyte imbalances. They were receiving calcium to help drive down the phosphorus, or given phosphorus binders. So all of those are they've got an opportunity to see in true practice. From a nutritional standpoint, so for diets, oh, excellent, Yesenia, that your patient are good that they have that on Wednesday. What kind of diet do we want to tell? We say renal diet, but what are we really telling them to do? So we said it earlier, that would be the low sodium and the low proteins, correct? Mm-hmm. All right. So they're going to, if they do have proteins, we want them to have something called a high biologic value. Why a high biologic value? What does that mean? A high biologic value. If you hear something like that, what are you thinking? Nutrient dense. How about one that supplies the amino acids necessary for growth and cell repair? So they want to be complete proteins. Things like dairy products, eggs, and meats is what we're looking at. Someone did say complete proteins. So they should have a daily protein intake of 0.6 grams per kilogram of body weight. Oops. Now, what does that really mean? So when we're looking at protein, that's going to be about 40 grams per day. And unfortunately for a male patient, don't have the info for a woman. We're going to restrict their fluids to 500 mils to 600 mils more than the previous 24 whatever their urine output was for the day prior. So say, for instance, your patient peed out 15 mils. Then they can have 515 to 616 of their fluids the next day, okay? So a water intake of 1 to 2 liters per day is generally recommended to maintain water balance. What are we restricting the sodium to? How many grams per day initially? So only about 2 grams per day initially for sodium. So we're just not letting them go balls to the walls on that. Potassium is restricted as well, because remember, they suffer from hyperkalemia. So only about 60 to 70 milliequivalents per day would be appropriate. So phosphorus intake is going to be restricted. So we need to, foods high in foods like eggs, dairy, and dairy products and meats. Those are high in phosphorus, so we have to be mindful of that. How much, someone said high calories. So how many calories per day should they intake? How many kcals? And this will be provided via carbohydrates and fats, and they need that to prevent wasting and keeping their energy levels. So how much should they intake as far as their calories? So remember, we just can't say high fat, low sodium. So that's how much they should have, 35 kcals per kilogram each day. So they do put them on those 2,200 calorie, 1,800 calorie, 2,000 calorie diets and things like that to try to maintain that. Okay. All right. So let's look at how do we, assist with, treatments for folks that have chronic renal disease. So yesterday I talked about the hemodialysis. We talked about the arterial venous shunt. And the design of hemodialysis is to basically get to extrapolate out the toxic nitrogenous substances from the blood and remove the excess water. So how do they know how much to remove? Well, your nephrologist will make a decision earlier on of what they consider your dry weight to be. And what I mean by dry weight, it's like your baseline weight. And every time a person goes to dialysis, then the goal of that treatment is to get the patient back down to their dry weight or their baseline weight. Sometimes they're able to do it, sometimes they're not. As I said before, dialysis is very stressful on the body. So the dialyzer or the machine is basically is going to replace the renal glomeruli and the tubules as a filter for the impaired kidneys. So that's how it works. You're going to also weigh them before and after dialysis. That is true, Ashley. So the blood that's kind of filled with all these toxins and nitrogenous waste products is diverted from the patient to the machine. And then the machine pretty much goes through that process and filters out the toxins and remove it from the bloodstream. I'm trying to see if your book has a picture of that. Let me look real quick. I want to say I saw one, so I'm trying to go back to where I was before. We have that. It's going to be in chapter, looking at my notes, I believe 54, if I'm not mistaken. And it actually lists out the common fluid and electrolyte disturbances and kidney disorders. So they do have that there. There's a chart. Right, it does return it back to the patient pretty much cleaned up. So it's like they get a new volume of blood to work with, kind of fresh and clean, without all the toxins or anything like that associated with it. So it's a good deal it works really well, but all of the fluid shifting just really wreaks havoc over the body. Just wanted to see if I can find this machine real quick. And if I can find that, then we can just roll on. And there's different types of dialyzing machines, but when you hear hemodialysis, this is basically, the blood that we're dealing with. So everything related to, body substance isolation would be fair game to be in play. And there's actually a vignette as well for chronic renal failure, so you could do that case study that's in your book. So the dialysis part starts around page 1548 in your textbook, and it talks about the different dialyzers. It talks about the arterial venous shunt and kind of give you a better visual as to what's actually going on with that particular individual. So they look at the AV graft, they cover, the care related to that, and then they actually show a couple of machines. They don't dissect the machine, but they actually show you a couple of machines that can potentially be used. Dialysis machines used to be humongous, and they have really narrowed them down to almost be as transportable as a monitor, as if you're transporting a patient from one room to another room. But there's different types, as I said before. They have, continuous renal replacement. They have some for CVVHD. So there's different brands, I guess is what I'm really trying to say. So they can have continuous venous, or they can have continuous, arterial venous. So there's different types of dialyzers. We're not going to test you on the variant types of dialysis. I think the bigger picture here is understanding what to do with a patient that is on dialysis, or if you come across that patient, how do you assess them? How do you manage them? That's more of what this process is. When you get out into your respective clinical practices, then you'll see the variant types of hemodialysis that could be done. So I'm going to finish up on talking about the dialysis part. So things are done by either osmosis diffusion or ultrafiltration. It keeps the buffer system maintained by using dialysate to a dialysate bath that's made up of bicarbonate and acetate. They usually give heparin to keep the blood from clotting in the dialysis circuit, so that's not uncommon. You can receive certain medications during dialysis, so if they feel you need Epigen, they can give it to you. If they feel that you need an antibiotic, they can give it to you. Some medicines they don't give because of the dialysis or the process of dialyzing will actually take it out. The treatment's usually about 3 to 4 hours, and that's the reason why they have a lot of weakness and just feeling kind of crappy because their body's literally just been beaten up for the last 3 to 4 hours. So we've already talked about making sure we check for a bruit and a thrill. Sometimes they will have a temporary catheter. It's called a Quentin cath. And I'll spell that out for you real quick. And you may see it, it's in a patient's chest, and your book also talks about it as well, that they may have this type of a process versus an AV shunt, but it's still the same thing. The only thing we're going to do is just make sure that the line is patent. It's kind of like a central line for that individual. We don't do anything as nurses besides monitoring the patient and doing supportive care. The dialysis nurse, the one that people think of just sitting there and they're not doing anything, they're really doing a lot of monitoring of that system, making sure, that the patient's blood pressure's fine, they're tolerating the volume shifting very well. If there's any problems, then, they have to make adjustments and or call the physician. So their whole role is completely different than that of what we're doing. We're just hoping everything goes okay, and then we're going from there. It depends on when the patient the patient doesn't have to be NPO, but, they may want to hold off for a little bit to see how the patient takes it because they get nauseated and they may vomit. So all of those are potential things. Post-dialysis, once they take out the needles, then we're going to monitor that IV site for bleeding and making sure it doesn't get infected and things of that nature. So, sometimes that Quentin cath, and I'm going a little bit back and forth, and I apologize for that, but if they have that temporary catheter, it could be in the torso, it could be in the groin. So if they have it in the groin, that may be a little bit more difficult to compress the bleeding, and that's different than the AV shunt. AV shunts they usually put in the arms or in that area versus, you know, groins, and groins is not that clean. But we had a guy that came in post dialysis, and we put on 5-pound, 10-pound sandbags, and he was still bleeding. So we definitely had to give him give him a blood transfusion. It was actually hard to stop the bleeding post dialysis, and that's usually one of the complications. So any other questions that you can think of about peritoneal dialysis that you know, I can't say they're burning questions, but just those kinds of questions that you may have. Peritoneal is done at home. I'm gonna move to that directly. There are, if you can be dialyzed at home, but that requires a whole nother process. But for now, for the purposes of, you know, NCLEX, HESI, etc., just understand usually hemodialysis is either done in the hospital or at a dialysis facility. And then I want to talk a little bit about, because I mentioned Procrit already, or Epigen, and there's a nursing management or assessment, you know, related to if you're going to give a person like Procrit and what you need to do. So what do you all know about Procrit or Epigen? So let me just go back with Epigen. So what do you know about Epitin alpha is the real, the generic name. So Epitin alpha, which is Procrit. What do you guys know about that in relation? What is it designed to do? What is its purpose? Why do our end-stage renal disease patients receive it? So if you're not really sure what I'm talking about, this is what I'm talking about here. So what is that? Why do we give it to our end-stage renal disease patients? What purpose does it serve? So we're giving it to, which blood are we trying to increase, or what blood? Okay, so red blood cells. All right. So what be more specific? What specifically of the red blood cells? Okay. Hemoglobin and hematocrit, but I'm gonna focus more on the hemoglobin, okay? All right, so because that kind of lets us know if we're losing blood, does it not? That's when we're doing our lab values, our complete blood, our CBC, and we're looking at blood loss, then we're kind of looking at the hemoglobin and hematocrit, more specifically the hemoglobin. Okay, so what's normal hemoglobin? What's the normal range? 12 to 16. Okay, perfect. So when would you not consider it to be a good idea to give Procrit or Epitin alpha? If what is normal? Hemoglobin. So if normal is 12, if the number is 12 or above, then should you give the Epotin alpha or the Procret? Should you give any of those things? Why not? What's the risk if you do? Clots. Perfect, Harmony. So just, you have to, yes, we're giving this to help with the anemia, but if we have blood levels that are within normal ranges, then why would we be giving it to increase red blood cells or to increase hemoglobin? Does that make sense? So we don't want to now cause them to start having clots because we got all these blood cells hanging around. So that's very important in a person that has end-stage renal disease, because remember, they're having the anemia, we're trying to replace it. And even if we did prescribe Epotin alpha, it takes about 4 to 6 weeks to start working anyway, which is the reason why they started early. So when they start going through the process of the dialysis to help minimize that anemia, then they're going to start on this daily dosage of it. But if the hemoglobin levels are normal, then we have to be really cautious about continuing that process. Do we want to wait for it to, drop low? No. But we still want to be mindful that this may be something that warrants a physician's attention or something like that. We just don't want to, be like, okay, well, it's normal. We're going to keep giving it. We're going to get it higher. We don't want to do that. Does that make sense? Okay. Oops. So, all right. Looking at diet for the renal patient, which we've already, we discussed already. If we're talking to our patient about the low phosphate diet, right? What things would we tell them to stay away from? We just covered that. Okay, soda. But we're talking more of the phosphate part. Remember, we talked about all the different restrictions, the phosphate restrictions, the protein restrictions. Remember all that I just covered recently. So this is kind of a check to see if you guys put those pieces together. Salt, milk, so dairy products, meats. So, don't let go of the data like, oh yeah, I'm gonna remember this. Make sure you commit those things like, the organ meats and all of that. If we're supposed to be having, restrictions, then know what falls underneath those restrictions. So foods that are high in phosphates, those will be the things you want to make sure that you decrease. Okay. What's the first sign of a person having diabetes? What would you expect to see? All right, we got the polyuria. I get all that. So is that a concerning component? Would 3Ps? It is a lot of urine, but you would expect that, right? Okay, so the confusion, the disorientation, the lethargy, those would be the things that would be significant. You would expect them to have the high urinary output. Okay, I don't know if that's necessarily reportable because we already know they're going to have large volumes of urinary output. So that's not to me, that wouldn't be something that would raise my eyebrow. Things that cause a person to have diabetes insipidus. So if they had, if we knew they had a brain tumor, okay, but now we know why they have diabetes insipidus. So to me, that wouldn't be something to report to the healthcare provider, because that's basically how they got the DI in the first place. You know, having a low specific gravity, do I feel I need to report that? Well, really not. I don't think so, because that person already is going to have low specific gravity because of the fact that they have DI and they're putting out large volumes of urine. Does it make sense? So things that you should understand as the cause as to why the person has diabetes insipidus, that would be, those are normal findings. But the things that, like if their mental status changes, now that's significant. Does that all make sense? Right. You don't need to report things you already expect, because you're already expecting them. You don't need to report things like the causes. Now, if your patient for some reason in the hospital fell and hit their head, now that would be something different, correct? You would report that part, but not something that's already transpired as the reasons or the risk factors or the causes for why they have it in the first place. And you would expect their sodium level to be high or low. You'd expect it to be high. So if it came back high, would you report it? Not really, because you already know this is what it's supposed to be. So think about those things as when you're putting your pieces together. Okay, so these are things that I'm expecting to happen. Okay, they happen. Okay, this is how I know that this is this disease. This only confirms that this is this exemplar. So if this is, something like mental status, or all of a sudden I'm having heart problems and this is not a part of that process, okay, then now I'm going to report that. All right. Before I'm just kind of doing a recap before I go to peritoneal dialysis. So that's all that I'm kind of doing, just because I know I've been throwing a lot of stuff at you for the last 5 hours of Zoom sessions. So we in CKD, we talked about maybe prescribing a calcium binder. Give me a name of not a calcium binder, but a phosphorus binder. Give me a name of a phosphorus binder that can be used to help your CKD patients. Okay, what else? What else can be used? Can we use that? And if not, why? And if so, why? Right, but we already said in CKD, what electrolyte imbalance do they have? Don't they have hypocalcemia and hyperphosphatemia? Okay. So don't get stuck on one medicine. Look at I gave you your common electrolyte imbalances, right? So your common electrolyte imbalances were what? Make sure I don't get them all mixed up. All right, so your common electrolyte imbalances. The first one was sodium and water retention. Hyperkalemia. hyperphosphatemia, hypocalcemia, and hypermagnesemia. And their acid-base balance would be what? You only have two choices. What will be their acid-base imbalance? Respiratory or metabolic? Metabolic acidosis. Okay, so going back up to these are your imbalances here. Your water, your sodium retention, hyperkalemia, hyperphosphatemia. So if you wanted to decrease phos, then you could give them something, a phosphorus binder, right? If you wanted to increase calcium, because if you increase calcium, then what happens to the phosphorus? It decreases, it goes down. So, you know, don't let go of, okay, this is phosphorus, I'm only going to treat with phosphorus. You may be able to treat it with a calcium, so that way you can decrease the phosphorus. So those options are available. So remember, you have all these tools in your toolkit. Don't pigeonhole yourself into only this can only work. So there may be other options that may be applicable, and you don't want to, you know, you don't want to have that or leave that off the table. Okay. So, you know, just keep in mind that there's that you have sometimes more than one med that can actually get the same job done. Okay, so in CKD, when you have a patient that's been on hemodialysis, you know, we already talked about the waste products that's removed. Will they need more or less protein in their diet? Tiris and Najwa, why more? And the rest of you, why less? So Daniel, Ashley, and Yesenia, why less? They personally can't excrete it, but what can help them with that process of excretion? Okay, so dialysis can help them excrete it. So if dialysis is getting, what does what does protein do? Let's maybe if that'll be a better direction for that one. What does protein? It builds tissue. It's a building block for what? Oops, I hit the wrong button. Hold on. Okay, it's a building tissue, building muscle. Okay, so once they start on hemodialysis, we've already talked about the dietary regimen. Dialysis removes those waste and waste products. But if it's used to build muscle, and if we're getting rid of it, how do we find the balance? Uh-oh, I got the eerie silence again. Okay. So if dialysis pulls off the waste products, we also use proteins for that too, right? So if we're not giving them protein, we have to increase the protein to compensate for the removal of the protein. There you go. See, good thinking. Good thinking. I like it. That's okay. So if we're taking it away, this is one of those, those unforeseen, if you stop short, then you're going to miss it. So this is why I keep saying don't stop short. You got to understand the whole process. We need it for tissue healing, etc. But if we're pulling it out, we got to increase it in those patients, just in those patients. So I don't want you thinking that's for everybody. Okay. So they're going to encourage more protein because they're removing the urea and the creatinine in dialysis. So we're going to give them more protein to compensate for that. Okay. All right. So let's see what other questions I can ask you to kind of get you thinking about, directions and how to kind of compile all these little pieces together. Remember remember your delegation responsibilities, who can do what and what, when, where, and why not. So remember all of those. Remember, if you give a medicine to treat an abnormality, it can actually push the person to the other side. And even though you know it can push the person to the other side, know the signs and symptoms that would be displayed when they hit the other side. Does that make sense? So, don't say if I give some, don't just know that if you give somebody 3% sodium chloride to treat hyponatremia, they can end up with hypernatremia. That's true. But how do you know that they're going to have hyponatremia? What signs and symptoms would you be looking for on the other side? Okay. For elderly patients, since their skin has lost the elasticity, and how do you tell if they are actually having poor skin turgor? Where would you check? What area will not have that significant loss of tissue elasticity? Sternum and forehead. Good, Amy and Isra. You could look at the tongue for, I'm not sure if there's tongue turgor, but you could look at the tongue for dry mucous membranes. You could do that. But if we're talking about skin, then the area of the torso, the sternum area, and the forehead are areas that's less likely to have, weak or sagging tissue would be the best way to put that. Okay. I'm trying to see if there's anything else that I want to talk about before I move on to peritoneal dialysis. So I just kind of take a break and charge you up and then go on to the next piece. And then I think that'll close us out. What would be, how would you know your patient, your chronic kidney patient, their I guess, since they have the abnormality of sodium and water retention, how would you assess that? How would you assess sodium and water retention? I think somebody talked about that earlier, besides edema. I want an objective. Edema is objective. Right, Ashley talked about weight. What else? Besides lung sounds. We don't really look at specific gravity in those folks. Daily weights, and what else? So the other thing would be blood pressure. Those would be the things that I would look at. Those are things that I would monitor in a patient that I'm concerned about, water, sodium and water retention. INOs, remember, chronic kidney disease, they're going to end up as, unequal intake and output because they are not peeing out. They're taken in, but they're not peeing out, okay? And cap refill, you have chronic kidney disease, probably related to hypertension or something like that. So that wouldn't be a real good indicator. Makes sense? What happens to the BP? You're looking for, if they have volume overload, that may stress the heart out and increase blood pressure. I'm saying temperature, but I meant blood pressure. So you want to monitor for that. Because remember, sodium and water retention equals increased BP. Go back to your renin and aldosterone system. So that's how, if they don't treat them with meds, then the blood pressure goes up. Remember that, Tiris? Okay. All right. There was one other thing I think I wanted to mention about that before we roll on. Okay, so if you're treating somebody with hyponatremia, and we're deciding that, their hyponatremia, say their sodium level was 110, we already know we're going to give what? What solution are we going to use? A hypertonic solution, give me a name. It'll be 3%. Okay. So how do you know your patient's in trouble? Because remember, it's going to increase the sodium, but if you're increasing sodium, and this is tied into the question I just asked you. So if we're increasing sodium, then we're also increasing what? Not just chloride, water. So we're increasing sodium, we're increasing water. So give me a sign or a symptom that a patient may have if we're increasing water in their body. JVD, okay, and it's distended, edema, crackles. So how do you know if they have crackles? You would have to assess the lungs. So you see how those pieces tie back together? So just don't say, they're going to have fluid overload. What things would you be looking for? I'd be looking for edema. I'd be looking for shortness of breath. I'd be auscultating breath sounds to see if I have crackles or rales. So don't stop short. You've got to lay it all out. Some of this stuff you guys already know, but you stop it because, okay, so they're going to have shortness of breath or they're going to be volume overloaded. But what does it really mean to be volume overloaded? Okay. Does that make sense? And I keep saying don't stop short, and you're like, what do you mean don't stop short? It's just because you you know the things, but you kind of stop it at one level. You don't go to the next level, which would be to explain what it is. So, continue the process of, okay, so how do I know this? Well, what would I do to check and see if they have that? That will be the way to not stop short, so you don't leave anything off the table. Once you get done answering those questions, then, you should be A-okay. So if you're looking at fluid volume excess, would your pulses be weak? What would they be? Exactly. So you got to remember what it's going to look like in the patient. That's why I keep saying don't stop short. And the bounding is correct. So we have to continue to not stop short. So remember, I said you need to know what the patient's going to look like before and after. What's my signs and symptoms? What am I expecting to see? So all of these things are what you would expect to see in your patient. Okay? So, those things are always, they're always that, that iffy kind of thing, but you got to keep going. You don't let it stop at one piece. Once you start stopping, you will stop all the time. And this is why you can't stop. This is why you have to keep going. Because if you don't keep going, then you're going to end up, on the other end of the spectrum, is what you don't really want to have. Okay? All right, so last thing for the day, and then, go out and do your Easter egg hunt, and it looked like it's going to rain or something like that. I hope not. Okay, so peritoneal dialysis. This is the one that they can do at home, a lot more transportable. What I mean by that is this individual can do it at home. It's just a couple of hours out of their day. It doesn't mean that they don't have deficits related to to peritoneal dialysis. It doesn't mean that they won't have any complications. It just basically means that they don't have to stay hooked up to a machine for 3 to 4 hours. So the goal of peritoneal dialysis is, again, to remove toxic substances and metabolic waste and try to restore fluid and electrolyte balance. So it may be the treatment of choice for patients who are not able or who are unwilling to do hemodialysis or renal transplantation. Okay. Exactly. So you can attach it. Ashley's sister, does it at night when she's sleeping. So patients that are more susceptible to rapid fluid, electrolyte, and metabolic changes that occur with hemodialysis experience less problems with a slower rate from the peritoneal dialysis. So what membrane are we using, and where is it located? This is not a trick question. We're using the abdomen, okay, the abdominal wall, but what membrane is it? Or forget, it's in the word, so you can't forget. You're using the peritoneal membrane, and that covers the abdominal wall, and that peritoneal membrane serves as a semi-permeable membrane. So they're going to use dialysate fluid too. They're going to put it into the peritoneal cavity through an abdominal catheter, and they're going to do it at intervals. Once the solution is introduced, once it's in the peritoneal cavity, then those waste products, the uremic toxins, are going to clear from the blood. So diffusion and osmosis will occur at that time, and it will help the waste products be removed from the area of higher concentration to an area of lower concentration, which is going to be the dialysate, through the peritoneum. So this movement is kind of known as clearance. So they have this big dialysate bag, this tubing, and then they're going to have another bag for all of the toxic stuff to collect into. So since it's going through the peritoneal membrane at different rates, adjustments to the time and the amount of fluids are usually made. So they're going to do inflow, then they're going to do dwell time, and then after dwell time, they're going to look at outflow. So this can usually, take 36 to 48 hours to achieve what hemodialysis can do in 4 to 6 hours. But people choose it so that way, IV pole in case the electricity goes out. If you have that, then that'll be great. So, sometimes people choose the hemodialysis, but it's just as harsh on the system. So there's several different approaches that can be done. There's an acute intermittent peritoneal dialysis. There's a continuous peritoneal dialysis. There's a continuous cyclic peritoneal dialysis, but they're all designed to do the same thing, is to get rid of the toxins. So, continuous means, it's at home, but done by the patient or a trained caregiver. It allows for the patient to have more freedom and control of their activities, but they have to be seriously committed to to doing it. The continuous cyclic uses a machine to help pull the fluid through the peritoneum. So, they can walk around and do the things that they need to do. They can't go swimming though. So things to let you know that, your patient may have peritonitis or an infection brewing is that the dialysate fluid that comes out is cloudy, or the patient has nausea, vomiting, fever, and chills, and a belly pain. At that point, they're going to require aggressive antibiotic therapy. So we don't want cloudy, nasty looking dark fluid coming out of draining back into the bag. If we suspect it, then we need to send the fluid to the lab for gram stain and culture, and we want to treat it appropriately. So we have to adhere to, if you do PD or you talk to your patients about PD at home, then you need to make sure they're using the strictest sterile precautions with the mask and the gloves and the gown during the assembly of the equipment and the discontinuation of the equipment. So if the patient starts to have recurrent peritonitis, then they're going to take out the catheter and do alternate dialysis until they can figure out what's going on. So the goal is to maintain fluid balance and make sure the patient's hemodynamically stable. They try to get the patient within 2 pounds of their dry weight, so it's almost 1 kilo. Keep the vital signs stable and have good skin turgor and normal oral mucosa that indicates the patient's well hydrated. Last thing is kidney transplantation. And, I don't know a lot of folks, donating organs and things like that, but that's their only other option. And I think the most recent public kidney transplantation would be with Selena Gomez and her best friend. So your dad gave his to his brother. And you know what? Sometimes that happens. Interestingly enough, sometimes families are not even the close match. And there's a lot of work that goes into transplantation identification. The cells have to be compatible. So they have a test called histocompatibility. They have to make sure that they have the most minimal risk of the person developing a rejection. So there's a lot of things that go into what's all needed, what type of, who would be the best match. There is a kidney transplant list, and that list is depending on how sick the person is. But before they were transplanting folks with kidneys and things like that, and then people get the new kidney and they'll continue the same behavior that they had prior to the kidney transplantation. So now the organ donation, Southwest Organ Donation, and all the organ donation centers have now put you don't get a kidney if you're still drinking, smoking, doing drugs, etc. And they test your blood, your urine for all of it. So if you violate that process, then your name goes off that list and you fall in wherever you fall in. So Ashley saying that her aunt was a match for her sister, but my sister wasn't on the list, so she couldn't donate. Oh, wow, that's terrible. Wow. but the person's old kidney stays in the body. They don't take it out. They implant in the new kidney, and they keep the vasculature of the patient that needs the kidney, so that they can attach that vasculature to the new kidney. The person who's going to have the most recovery is going to be the individual that donated the organ. So they have a lot more recovery time than the person that receives the organ. So, but there's, a lot of medical evaluation, not just medically, but psychologically, because, that person's losing a kidney, and, hopefully later on down the line, they don't need it. So there's other things that may come into play. They do keep the old kidney in there. They do not take it out. So it stays there. The location of the kidney may be more forward in the belly versus outside the belly. I'm not really sure of the rationale as to why, Yesenia, but I have a student who actually had a kidney transplant, and it's actually closer to the front of his stomach. So during assessments, no one can do a belly assessment on him because they would actually be pressing on his kidney. Preoperative management, they want to make sure that their labs are good, they don't have any infection, everyone's ready to go. And, you may get a call and say, we need you to be at the hospital in an hour. We have a donor, and, things just start moving from there. So we always want to assess for potential rejection of the transplant. We want to make sure we're preventing infection. So we can't just kind of half-ass do our PPEs. We're going to monitor urinary function, psychological concerns. People think once they get the kidney, they don't, I'm done with the medicines. Actually, no, they may have more medicines because now they have to have immunosuppressants like cyclosporin or anti-rejection meds, and the side effects related to those. So there's still a lot of follow-up and work that's done after that. So just, a couple things to, to kind of consider as you're dealing with folks with transplants, that, if they don't take care of it, they will definitely lose it. And being placed on that transplant list a second time may not necessarily be easy. So they may not get that second opportunity. Makes sense? Okay. So I think we've covered all of the med-surg. Rejection happens when rejection can happen at any time. There is no real time frame on rejection. The organ can be transplanted in, and the patient can reject it the next day. So those first 24 to 48 hours, the physicians are running a lot of labs. They're looking at, did the kidney kick in and start functioning really well? Do we have a decrease in urinary output? So those are things that can hamper the acceptance of the new kidney or the functionality of the new kidney. Ashley said her sister had an autoimmune system disease, and that can attack the new kidney. It doesn't necessarily mean it'll show right away. The person may actually have everything moving in the right direction, and then it could be a week, 2 weeks, a month, 2 months, 4 months, 10 months, 5 years, and now we have a rejection. Most of those will last they'll give them a 5 to 10 year window with good management. But you can have, say you got sick, and then, that may be a process to start your kidney rejection. You start by having low urinary output and then having high BU and creatinine levels. You don't get the kidney and stop seeing the physician. You're monitored closely after that transplant, or at least you should be. I know for the nephrologists that I've worked with prior, their patients were in their offices. They have a whole protocol to follow up on those patients to make sure that kidney or even liver, but since we're talking about kidney, I'm going to stick to that it's actually functioning properly. So, questions? I feel like I've like raked you guys over the coals. All right, so I will download this video, and it should be up within the next 30 to 45 minutes. It just depends on how long it takes for it to download. And that'll give you some time to, you know, get your thoughts together. I would probably take a break for about an hour or so just to regroup and reset. And then pray for us. I think you guys will be fine. I think you'll be fine. Just remember, keep it in silos, and then areas where, you know, I've already talked about where things cross over or are linked. When I say crossover, they're linked together, then make those connections at that time. So other than that, you guys are welcome. We'll hit perfusion starting on Tuesday. And some of this will probably come back up. We're going to go back and revisit, you know, coronary artery disease. We're going to go back and revisit, you know, deep vein thrombosis. We're going to go back and look at all of those, and then we'll add in elimination, etc. So all those other labs from nutrition, they're back on the table again. So your LDLs, your HDLs, your cholesterol levels, we're going to go back to that. But for tonight and for today, I would just focus on this test, and then you do have after the test to do your Lippincott. And then I know you're going to feel like brain overload, but we're hitting that last tail end of the semester, so this is not the time to be given up. This is the time to actually dig deep and, you know, stay strong, you know, minimize other distractors that can literally tank your success, okay? Failure's not an option. I hear you. All right, guys, be good, and we will see you on tomorrow and Tuesday. You're welcome, guys.